Hello, and thank you for the invitation to participate in this debate on a very timely topic organized by the Society of Breast Surgeons, the Brazilian Society of Breast Surgeons. So we're here to discuss whether to irradiate or not to irradiate after pathological complete response, and to potentially ask the questions so whether we should or should not, and also whether we're ready for this type of de-escalation, and also which case scenario. I'm Terry MAMOUNAS. I'm a medical director of the breast program and research activities at the Advent Health Cancer Institute in Orlando, Florida. And it's my pleasure to join you for this debate. So if we look back at the evolution of clinical rationale for neoadjuvant chemotherapy, we know that originally we used neoadjuvant chemotherapy to convert patients with inoperable or locally advanced breast cancer to surgical candidates. And then when we started to apply neoadjuvant chemotherapy for patients with operable disease, we found through randomized clinical trials that there were no significant differences in efficacy, whether you give the chemotherapy before or after surgery. And of course, with that in mind, neoadjuvant chemotherapy became a reasonable alternative to adjuvant chemotherapy that has potential clinical advantages in appropriate candidates. And I underscore that because some patients benefit more so from neoadjuvant chemotherapy than others. And of course, initially, we looked at surgical de-escalation by converting mastectomy patients to candidates for breast-conserving surgery. And then more recently, as you all know, we're able to de-escalate the surgical management of the axilla by converting patients from axillary lymph node dissection to sentinel lymph node biopsy. And what we've learned from neoadjuvant chemotherapy studies that if we achieve a pathological complete response, patients have significantly better outcome versus not achieving a PCR. And the pathological complete response has become a surrogate endpoint for neoadjuvant chemotherapy efficacy. Over the years, we have witnessed a significant increase in pathological complete response rates with the development of more active chemotherapy regimens. And this shows you that regimens that have improved disease-free and overall survival have also continued to improve pathological complete responses. So if we look back at the days of CMF-based therapy, only single-digit responses, 7 to 8%, double with the anthracyclines, double again with the taxanes. And all these, of course, have shown benefit in disease-free and overall survival. And more recently, for patients with HER2-positive disease, with the addition of single anti-HER therapy and dual anti-HER therapy, we have pushed pathologic response rates all the way to 55 to 60%. And also, again, more recently, for patients with triple-negative breast cancer, we were able to increase pathological complete response with the addition of carboplatin, and of course, also more with the addition of a checkpoint inhibitor. And again, all these interventions have shown improvements in disease-free and mostly also in overall survival. In addition to the effect of neoadjuvant chemotherapy in the breast, we also witnessed similar effect of neoadjuvant chemotherapy in axillary nodal metastasis. And of course, in early randomized trials, when we compared neoadjuvant chemotherapy to surgery first, we saw a 30 to 40% downstaging, pathologic downstaging in the axilla. And this was the NSABP B18, also the ORTC trial, the ECTO trial, as well as NSABP B27. Nowadays, of course, with more active regimens, we see even more downstaging. 60 to 75% of axillary downstaging is expected for patients with triple-negative breast cancer or HER2-positive breast cancer treated with modern therapy. And of course, that gives us the potential to de-escalate axillary surgery. And we have demonstrated that we can convert patients from axillary lymph node dissection to sentinel lymph node biopsy. Now, this is not a talk about surgical management of the axilla, but it's important to mention how we have managed to convert patients in the neoadjuvant setting and downstage them and reduce the extent of axillary surgery because it pertains to the introduction of radiotherapy omission. So we know that for clinical N0 patients that are clinical N0 before neoadjuvant chemotherapy, when we do sentinel lymph node biopsy after neoadjuvant chemotherapy, it performs equally well as if we do sentinel lymph node biopsy up front. Same false negative rate, same identification rate. But also for clinically N+ patients, clinically node positive patients before neoadjuvant chemotherapy that convert to clinical N0, and then undergo sentinel lymph node biopsy followed by an axillary dissection, we have shown that the false negative rate is a little bit higher than we have expected, higher than the 10% we anticipated, about 12 to 14%, but is lower to single digit 7 to 9% with dual agent mapping, removal of 3 or more sentinel nodes, and also the use of immunohistochemistry. But more importantly, more recently, we have shown that adding the removal of the clipped node, the node that was used to be biopsied that have a clip in it, to the sentinel lymph node biopsy procedure, something that we now call targeted axillary dissection, further reduces the false negative rate to around 4 and 5%. So we have improved the accuracy of sentinel lymph node biopsy with again removing more nodes, dual mapping, but more importantly, with the addition of the removal of the clipped node. It's very important to actually accurately determine the pathologic status of the axilla after neoadjuvant chemotherapy, short of doing an axillary lymph node dissection, because there's a lot of implications in terms of systemic therapy after neoadjuvant chemotherapy, but also, as we will discuss today, in terms of the potential omission of regional nodal irradiation for patients that convert the nodes from positive to negative. So the question that we're about to answer here is, can we omit the use of regional nodal irradiation in clinically not patients who convert to YPN0 with neoadjuvant chemotherapy? And of course, we have a lot of evidence that patients who undergo upfront surgery and have found to have positive axillary nodes, there is significant benefit from adjuvant regional nodal irradiation, including irradiating the chest wall after mastectomy, or when we add regional nodal irradiation to whole breast irradiation after lumpectomy. So this benefit has been very well established, and I will show you some of the data in the next slide. However, the same set of data that were applied to patients that had negative nodes and had upfront surgery showed no benefit from regional nodal irradiation or post-mastectomy irradiation. So it's important to give it for non-positive patients, but doesn't improve outcomes for non-negative patients. And of course, we now have a category of patients, as we use more and more neoadjuvant chemotherapy, patients who present with clinical and positive disease and become YPN0, pathologically non-negative after neoadjuvant chemotherapy. What we know about these patients is that, as I will show you also, that they have lower rates of locoregional recurrence compared to those who remain pathologically non-positive. But the big question is, do these patients behave more like non-negative and don't benefit from regional nodal irradiation, or they behave more like node-positive, where they would benefit a lot from regional nodal irradiation? Now, this is again the data showing that post-mastectomy irradiation and regional nodal irradiation in node-positive patients improves outcomes. These are the data from the Oxford overview analysis on the left, showing a significant reduction, whether there were 1 to 3 positive nodes or 4 or more positive nodes. And this is a reduction in locoregional recurrence, any recurrence, and also breast cancer mortality. So this benefit is very well established. And again, some argue that these are older data with a lot higher locoregional recurrence rates. But what about more modern data? And that is shown on the right side in the MA20 trial that evaluated the addition of regional nodal irradiation for patients who had breast conserving surgery. And as you see here, showed a significant improvement in disease-free survival, distant disease-free survival, and a trend towards overall survival. And similar data were shown in the ORTC trial, looking again at regional nodal irradiation for patients with high-risk disease. So when it came, though, to patients that received preoperative chemotherapy, there were very few data sets that one can look to find out what are the independent predictors of locoregional recurrence and what is the risk of these patients to develop locoregional recurrence. So we went back in around 2012, we published this paper from data from the NSABP B18 and B27. As you know, B18 compared preoperative AC to postoperative AC, 4 cycles, and B27 had 3 neoadjuvant arms, AC times 4, and then surgery, AC followed by docetaxel, and then surgery, and then AC followed by surgery, and then docetaxel as adjuvant therapy. So we combined all the preoperative arms from these two trials, and this included 3,088 patients and 356 locoregional recurrences as first events. And this was, again, the preoperative AC arm of the B18 and all the three arms of the NSABP B27. And we asked the question, what are independent predictors of locoregional recurrence? And what we found was interesting. There were different, to some extent the same, but also to some extent different independent predictors, whether patients received lumpectomy and breast radiotherapy or whether they received mastectomy. I'd like to mention, of course, that in the B18 and B27 trials, we did not use post-mastectomy radiotherapy, and we did not use regional nodal radiotherapy in patients that have breast conserving surgery. The only thing that was allowed in the trial was just breast radiotherapy. So that represents a group of patients that were treated with no regional nodal radiotherapy by protocol, and were followed, of course, very carefully. So a uniform group of patients that we can identify independent predictors of locoregional recurrence. So for lumpectomy patients, we found three independent predictors of locoregional recurrence. The age of the patient was a significant predictor, reflecting mostly local recurrences in the breast. Clinical nodal status was an important independent predictor, positive versus negative. And then the combination of breast and pathologic nodal response. In other words, whether patients became node negative and had no PCR versus non-negative with PCR, and whether they were node positive versus non-negative with PCR. For mastectomy patients, age was not an independent predictor, but clinical tumor size was an independent predictor. And again, nodal status was an independent predictor, and a combination of breast and nodal pathologic response, again, remain independent predictors as in lumpectomy and breast radiotherapy patients. So based on this data, we created a nomogram to actually estimate the prediction of 10-year risk of locoregional recurrence after neoadjuvant chemotherapy. And what we see here on the left are the lumpectomy patients, on the right, the mastectomy patients. And for the lumpectomy patients, on the left, is clinically not positive and then clinically not negative. And then the x-axis is the age of the patients. So what you can see here is that patients that started with clinically not positive disease and remain pathologically not positive have substantial risk of locoregional recurrence. That went down as the age of the patient increased, but it was very high for the younger patients, for example, like around 25%. But then if patients converted to node-negative disease, either they were node-negative at the beginning, although the majority, obviously, because they were clinically not positive, were also pathologically not positive. Well, if they converted to node-negative but did not have a PCR in the breast, had better outcomes, but still in the younger ones went up to about 20%. But if they had both PCR in the breast and negative nodes, then the rates of recurrence were lower, and again went down with the age of the patient increasing. And then when you follow to the clinically non-negative lumpectomy patients, you see the same pattern, only the risk of recurrences now are less. So you could have started at clinically non-negative, but still had some nodes positive, and the risk was higher. It was less if there was negative nodes, but no PCR in the breast. It was even lower if there was PCR in the breast and negative nodes. And the same you can see on the right side with the mastectomy patients, clinically non-negative first, clinically non-positive after, and you see essentially the same pattern, how the risk goes up for the pathologically not positive patients, even more so if they were clinically not positive before, and then it moderates for those that had negative nodes but no PCR in the breast in the green, and then much less risk of locoregional recurrence for those that had PCR in the breast and negative nodes, even if they started as clinically not positive, and even if they had higher tumor size, like up to 4 or 5 centimeters, you see that the risk of local recurrence is about 5-6%. So again, that precipitated us to say that maybe these patients benefit more like non-negative patients, and they don't need radiotherapy. So with that in mind, we initiated in 2013 a randomized prospective clinical trial looking at patients with clinical T1 to T3, N1, M0 breast cancer. And again, this was the NSABP B51 RTOG 1304 trial. Now, one comment here, the N1 definition was patients with clinical N1, which means patients with palpable or abnormal level 1 or 2 axillary lymph nodes that are not matted with each other, like in other words, fixed to each other or to surrounding structures. This is the definition of clinical N1. We'll discuss a little bit that later. And those lymph nodes that were abnormal had to be biopsied. At least one lymph node had to be biopsied by fine needle aspiration or core biopsy. Neoadjuvant chemotherapy plus anti-HER2 therapy was given for patients with HER2 positive. And if the patients then had pathologically negative nodes at surgery, and surgery would have been axillary lymph node dissection or sentinel lymph node biopsy with or without subsequent axillary lymph node dissection. Patients were stratified by the type of surgery, mastectomy, lumpectomy, hormone receptor status positive, negative, HER2 status positive, negative, adjuvant chemotherapy, yes, no, or breast PCR, yes or no. So we allowed patients that did not have breast PCR but had axillary PCR to enter the study. And then patients were randomized to no regional nodal irradiation, the no RNI group, or regional nodal irradiation RNI group. What that meant was that if patients had breast conserving surgery, they would get breast radiotherapy if they were in the no RNI group, but they were breast plus regional nodal radiotherapy if they were in the RNI group. Patients that had mastectomy and they were in the no RNI group received no chest wall radiotherapy and no regional nodal radiotherapy. In other words, no radiotherapy at all. And those that were in the RNI group received chest wall radiotherapy and regional nodal radiotherapy. So the primary endpoint was invasive breast cancer recurrence-free interval, or IBCRFI. Secondary endpoints was locoregional recurrence-free interval, distal recurrence-free interval, disease-free survival, and overall survival. We recruited 1,641 patients and randomized them. This analysis that we presented in San Antonio in 2023 and then published in the New England Journal in 2025 was a time-driven analysis pre-specified to the protocol at 10 years since the first patient enrollment. At that time, with a median follow-up of 59.5 months, we had 109 primary endpoint events, and this is compared to the 172 events that were required for an event-driven analysis. So we did not have enough to get the event-driven analysis, but we had reached the 10-year point, and the per protocol analysis of the time-driven analysis was presented and published. So if we look at the patient characteristics, there were younger patients, of course, in the trial. About 40% were under the age of 50, and about 16% were under the age of 40. 50 to 59, about 32%. And you can see here about 28, 26%, 60 or over. Black and African American patients were slightly overrepresented because they get a lot of triple-negative breast cancers, and they were more prone to be pathological complete responders and entered the trial. We saw that tumor size T2 was the most common one. About 60% of the patients were T2, about 20% T1, and about 20% or so T3. And then when it comes to tumor subtype, as expected, but almost about 80% of the patients in the study were either triple negative or HER2 positive. But if you break it down according to each subtype, triple negative about 20-some%, ER and or PR positive HER2 negative, about 20%, ER negative, PR negative, and HER2 positive, 25%, and triple positive, as we call it, about 31%. So a total of about, again, 80% of the patients were either triple negative or HER2 positive. 58% of the patients underwent lumpectomy, 42 mastectomy, and then axillary surgery, 55% was sentinel lymph node biopsy, and axillary dissection with or without prior sentinel lymph node biopsy, about 45%. And the majority of patients had also PCR in the breast. 78% of the patients had PCR in the breast, about 21% did not. And adjuvant chemotherapy was very common. Less than 1% of the patients received adjuvant chemotherapy. Now, this is the primary endpoint that we again presented and published in 2025, invasive breast cancer recurrence-free interval. As you can see, there is no significant or clinical difference between the two groups of the RNI group and the no RNI group. There were 50 events in the RNI group, 59% in the no RNI. The absolute difference at 5 years was 0.9%, less than 1%. And of course, has a ratio of 0.88, not significant, statistically significant. When we looked at the secondary endpoints, that of locoregional recurrence-free interval, distant recurrence-free interval, disease-free, and overall survival, we see that none of these endpoints shows any significance with none of these absolute differences being more than 1%. It was less than 1% in all, and some of them were almost identical. For example, locoregional recurrence-free interval, 0.5% absolute difference. Distant recurrence-free interval, no difference at all. Disease-free survival, 0.2%, in fact, favoring the no RNI group for 0.2%, and overall survival, you see 0.4% difference. Again, the no RNI group a little bit better, but not significant, of course. Now, we looked at subgroup analysis, trying to find some trends in terms of the benefit from radiotherapy, if there was any. So we looked first at the subgroup analysis by stratification factor. This was a pre-specified analysis. And as you can see on the right side from the p-interaction p-values, we see no significant interaction when we look at it according to the type of surgery, lumpectomy versus mastectomy, to the estrogen progesterone receptor status negative versus positive, to the HER2 status negative positive, whether there was PCR in the breast or not, yes, no or yes, and whether there was adjuvant chemotherapy. As you can see here, the point estimates all are around 1, and the confidence intervals are wide. And you can see sometimes a little bit of a trend, like mastectomy patients maybe a little bit more to the left. For example, HER2 positive patients, and then, of course, patients with no PCR in the breast a little bit more. But in general, none of this is statistically significant, indicating no significant interaction. We also then did an exploratory subgroup analysis looking at some of the other factors, such as, for example, the age of the patient, the race of the patient, tumor subtype, and the type of axillary surgery. And again, you see that none of it is statistically significant. Age is not, race is not, and axillary surgery was not. But the only group that shows some statistically significant interaction was by tumor subtype, when broken down by 4 different subtypes: triple negative, ER/PR positive, HER2 negative, ER negative, HER2 positive, and triple positive. So what we see here, actually, very interestingly, is that patients that have triple negative disease tend to actually do worse if they did not, if they received the radiotherapy. In other words, the hazard ratio favors the no RNI group. There was actually 2.3 times more risk of an event if patients did get radiotherapy versus those that did not. On the opposite side, ER positive, HER2 negative patients appeared to get some benefit. It wasn't statistically significant per se, but the confidence interval was about touch 1, but the hazard ratio was 0.41. So we'll discuss a little bit more about that. And HER2 positive patients kind of fell in the middle. There was no significant difference. A little bit trend to the ER negative, HER2 positives, but triple positives exactly the same. And then, as I mentioned before, axillary surgery did not make a difference. So what we concluded from this, that for patients who present with more biopsy-proven axillary lymph node involvement and convert their axillary lymph nodes to YPN0 after neoadjuvant chemotherapy, chest wall irradiation plus regional node irradiation after mastectomy, or whole breast irradiation plus regional node irradiation after mastectomy did not improve the 5-year IBCRFI, locoregional recurrence-free interval, distant recurrence-free interval, disease-free, and overall survival. And these findings suggest that downstaging involved axillary nodes with neoadjuvant chemotherapy can optimize adjuvant radiotherapy without adversely affecting oncologic outcomes. And of course, we'll continue to follow these patients for more long-term outcomes, as some studies in the past have shown that it may take years before any differences emerge from locoregional radiotherapy. Now, some comments on this data. We know, of course, that everything, once you finish a randomized clinical trial, by that time, the paradigm has changed in how you treat breast cancer patients. For example, a lot of developments in systemic therapy were not really included or included very little in the B51 trial. For example, post-neoadjuvant capecitabine for triple-negative breast cancer was not used. Now, you can say, of course, who would need it post-neoadjuvant capecitabine? Those with residual disease. So if the nodes were negative, but there was residual disease in the breast, they could have benefited. Neoadjuvant carboplatin was introduced late in the life of the B51 trial, so the majority of the patients did not get neoadjuvant carboplatin. Post-neoadjuvant TDM1 for HER2 positive patients with residual disease, similarly, was a little bit of a late inclusion there. Neoadjuvant pembrolizumab for triple-negative breast cancer, which made an important big difference, was not included at all. Pembrolizumab was not approved before the trial, the B51 trial was closed. And of course, now we also have benefit from adjuvant abemaciclib or ribociclib for hormone receptor positive HER2-negative patients that have neoadjuvant chemotherapy also and have residual disease or higher risk. And also, adjuvant olaparib has been shown to benefit patients with BRCA and germline mutations, particularly triple-negative that have residual disease. So all these developments will expand the pool of candidates for RNA omission in the future, but also will improve the outcomes of patients that actually participate in these studies and get pathologic complete responses. What about the exploratory analysis by subtype? Well, the triple-negative breast cancer patients, the findings are very interesting because, of course, they may represent a spurious finding just by chance alone, but we cannot explain well why patients who did not receive radiotherapy did better than those who received radiotherapy. That may be related to an immune suppression effect, maybe from regional radiation. There's some speculation to that. But also, we have shown in the past that there was less post-mastectomy radiotherapy benefit in triple-negative breast cancer patients, like in the Danish trials. These were randomized trials of post-mastectomy radiotherapy. They went back and looked at it according to subtype. The triple-negative patients did not receive a lot of reduction in local regional recurrence or survival benefit. And again, given the recurrence patterns of triple-negative breast cancer, it is unlikely that RNA benefit will appear in this group with more follow-up because most of these events in triple-negative breast cancer occur in the first 2, 3, 4 years, and most of the patients in B51 have been followed for 5 years, or at least 3/4 will be followed for 5 years, and the remaining for at least 3 years. The minimum follow-up was 3 years. So I don't think this will change. Now, why is that? I don't know, but in reality, it doesn't matter if we can conclude that patients don't benefit. Maybe they do a little worse, but then you're not going to give radiotherapy for these patients. For hormone receptor positive HER2-negative patients, we have to be a bit more careful because these are patients that have long-term recurrence patterns, although most of the local regional recurrence occur by year 8, 9, not further than that. But we need more follow-up for these patients. And also in these patients, we've seen large post-mastectomy radiotherapy benefit in the Danish trials. On the opposite of the triple-negative breast cancers, the ER-positive HER2-negatives had a lot of benefit both in terms of local recurrence reduction and improvement in distant recurrence and overall survival. Now, the other problem with these patients is that the PCR rate overall is low, particularly hormone receptor positive HER2-negative patients that have residual disease in the breast after neoadjuvant chemotherapy are more likely to have axillary metastasis after neoadjuvant chemotherapy. And if you have a false negative rate of the sentinel lymph node biopsy procedure, it is possible that some patients may have had residual disease that was not picked up. So it's important to improve the accuracy of the axillary assessment, particularly in this group of patients, with introduction of the removal of the clip node, the targeted axillary lymph node dissection, to make sure we get it right. And then some are asking, what about clinical N1 patients that potentially may have more than 3 positive nodes at presentation? It's quite possible. And in fact, we know that patients who present with clinical N1 disease, such as, for example, in the TAXIS trial that's was presented in San Antonio, that were patients with upfront surgery, we know that if they have clinical N1 disease, almost about half were found to have 4 or more positive nodes when axillary lymph node surgery took place. So we know that these patients may have been included in B51, but this percentage also could be higher for clinical N1 patients who are candidates for neoadjuvant chemotherapy. We will have bigger tumors. So it's possible, of course, if preoperative imaging identify multiple abnormal lymph nodes, those patients may not have or may be less likely to be enrolled in B51, but nevertheless, it's fair to say that a sizable proportion of the patients in B51 probably had more than 4 or more nodes, and nevertheless, the findings show no difference. Now, we didn't know who they were, of course, because sometimes imaging was not performed in all patients, aside from, let's say, an ultrasound or an MRI. So there, of course, are potential harms if we don't apply the B51 and TOG findings. There are clinical harms because you overtreat, resulting in increased risk of lymphedema, pneumonitis, cardiotoxicity. Of course, we know that there is a negative impact on breast reconstruction outcomes if we combine implant-based reconstruction and radiotherapy in terms of complications and cosmetic outcomes, and we are looking at that in the B51 trial. There are also patient-centered harms. There could be reduced quality of life due to pain, restricted mobility, and also increased financial burden and time commitment if a radiotherapy needs to be given. And also there could be system harms because there could be misallocation of RT resources if there are not enough resources, and widening this global disparity actually in treatment access, particularly in places that radiotherapy is not very easily accessible. So we have to take that into account. So to finish with trying to answer the questions that were asked in the title, to irradiate or to not irradiate after PCR, I think the results of B51 indicate that it's oncologically safe to not irradiate clinical no-positive patients who convert to YPN0. Of course, lumpectomy patients should receive breast radiotherapy. And again, these patients don't seem to have a lot more benefit at all with the addition of regional radiotherapy. We know that the complication rates increase with PMRT and RNI for patients who undergo mastectomy with implant-based reconstructions, who also have to be careful for those. For example, in the triple-negative patients, particularly young patients that undergo this type of surgery, do we really need to radiate when we see the data from the subset analysis? And then increased rates of lymphedema, of course, when adding RNI to axial lymph node dissection, we have to take that into account. Are we ready for de-escalation? I think we are ready because we have already de-escalated breast surgery and axillary surgery for patients who respond to neoadjuvant chemotherapy. I don't think it's a far-fetched idea to de-escalate radiotherapy for these patients. And we should be ready to de-escalate RNI in clinically no-positive patients who convert to IPN0, particularly if they also had PCR in the breast. And finally, in which scenario? Again, apply the results to patients who meet the criteria. We have to again acknowledge that triple-negative and HER2-positive patients with YPN0 are the prime candidates, and we have to be a little bit more cautious for the hormone receptor-positive HER2-negative. And for those, I would apply it for those to at least get pathologic complete response in the breast, because then that will increase our confidence that the pathologic response in the nodes was true finding, not a false negative sentinel lymph node biopsy. And until more follow-up, I think we should be cautious there. And of course, I re-emphasize again, we have to minimize the false negative rate of sentinel lymph node biopsy and favor the application of targeted dissection to make sure we get the axillary status right before we can omit regional node radiotherapy. And with that, I would like to thank you, and I look forward to the discussion and debate later on. Thank you very much.
Hi, good morning, Dr. MAMOUNAS. It's a great pleasure to have you on Saturday morning. And we are going to have questions from the audience, and probably they are going to do the questions in Portuguese. They'll have a translation. And se alguém quiser começar para fazer alguma pergunta, o Dr. Fabrício Benelli.
Bom dia, professor MAMOUNAS, excelente apresentação. Eu tenho duas perguntas. A primeira, nós temos às vezes uma discussão de indicação de radioterapia pós-mastectomia em relação ao tipo de mastectomia. Você tem nos seus dados as pacientes se foram realizadas nipple-sparing mastectomia, mastectomia skin sparing ou mastectomia radical? Houve essa diferença? Você tem esses dados no estudo? A segunda pergunta é em relação à adoção do resultado do B51 no seu meio, nos Estados Unidos. Aqui nós discutimos muito e, geralmente, paradoxalmente, nas pacientes triplo-negativas, ainda existe uma resistência a desindicar a radioterapia, ou seja, parece que aquele grupo que mais se beneficiou e não irradiar é aquele que existe uma resistência maior dos radioterapeutas em continuar irradiando. Então, gostaria de saber como foi a adoção dos resultados do B51 aí nos Estados Unidos.
So if I understand the question, the first question was for patients that undergo mastectomy. And I think that if that was the question, I think we can apply the results for post-mastectomy patients. We did not see an interaction in the effect of radiotherapy according to the type of surgery in B51. There was no significant interaction. So we don't see much more benefit in patients that have mastectomy versus those that had breast conservation, which, as I mentioned, they received also breast radiotherapy. And again, the patients post-mastectomy that undergo reconstruction, have something to lose, let's say, because of there is another radiotherapy in terms of cosmesis from the reconstruction, in terms of complication rates that go up for patients that receive radiotherapy. So I think we should be ready to apply the results in mastectomy patients as much as we apply them in breast conserving surgery patients.
Professor Mamonas, I don't know if you understood well the
Oh,
question.
maybe not.
Yeah. I asked if you have the numbers of patients that undergone nipple sparing mastectomy, skin sparing, or radical mastectomy, because we discuss a lot. Okay, patients who underwent nipple sparing mastectomy may have a higher risk of local recurrence. Do you have these numbers in your study?
No, good question. No, we do not actually. We're taking a better look now into the pathology reports that we collected in the study, but in the entry forms we did not specify the type of mastectomy. But we should be able to get some information when we review, and we also review like number of removed nodes and the axillary surgery as well. So to answer your question, I don't have an answer at this point, but hopefully we'll be able to produce results. But I would agree that if there's any concern after nipple sparing mastectomy in terms of margins, then I think you have to be very careful applying the results of the B51. Because we all have seen patients who, they get the nipple sparing mastectomy, but they may have even less than 1 or 2 millimeter margin. Now that's a different population of patients. But as long as the margins are widely clear, I think the results of B51 should apply.
Okay, and the second question is, how is the adoption of the results of the B51 in the United States? Because here it's like paradoxal. The radio-oncologists, they indicated more radiotherapy for patients, triple-negative patients, and in the paper, it's the contrary. Maybe the radiotherapy in this group is harmful. How is the adoption?
Yeah, I think people here adopt the B51 results more for the triple-negative patients. I think the group of patients that there is more reluctance are the ER-positive, HER2-negative patients, particularly if they did not have a PCR in the breast. But I think we should be able to apply the B51 results for the triple-negative subtype, because as I mentioned in my lecture, the median follow-up was about 5 years, and the minimum follow-up in B51 was 3 years. So most of the patients in the triple-negative breast cancer that were to have a recurrence probably had suffered that recurrence already. So I think the results on the triple-negative patients are more mature, if you like, than the results of the ER-positive, HER2-negative patients, because of the patterns of failure. So I will be very surprised if at some point B51 will show any benefits to the triple-negative patients, and it may continue to show the opposite, that in fact people did a little bit worse. Now again, subset analysis, are fraught with sometimes uncertainty, but it's very unlikely that the results, the events will go the other way in the next, several years. And now we're getting close to like an 8-year follow-up in B51, and hopefully we may have an update to present where all the patients will have been followed for 5 years. But I don't expect the results to change. I expect that, if anything, there is as I said, there's a long, there should be a lot more recurrences the other way to make up for the recurrences the difference in the recurrences that we see already in the trial. So I don't think that's going to be the case. So I feel very comfortable with triple-negative breast cancer. Some people, of course, say, well, if somebody's very young, did you have a lot of young patients? No, I mean, we did not. About 16% of the patients were under 40. But the fact is that these patients don't behave any different. Age was not a significant predictor of benefit from radiotherapy in B51 as well.
Okay, thank you.
Dr. Silvio?
Dr. Mamonas, eu queria saber, ainda em relação ao triplo negativo, porque essa é uma discussão muito frequente aqui no Brasil. O seu estudo teve um hazard ratio de 2,4 e muito poucos eventos para triplo negativo. vocês pensam em tentar aumentar essa casuística de triplo negativo especificamente para dar força estatística para o mundo, teoricamente, enxergar isso de uma maneira tranquila? Porque eu entendo sua posição, é convincente para a gente e ela tem crédito, dizendo que vocês acreditam nesses dados, mas existem muitas discussões paralelas para quem não participou do estudo em relação aos dados do triplo negativo. Existe alguma estratégia de vocês pensando em aprofundar nesse subgrupo ou isso é extremamente desnecessário e os números de vocês, para vocês, dizem tudo?
Acho que ele não entendeu muito, Silvio. Quer fazer a pergunta. Did you understand, Dr.
Did you
Mamonas?
understand?
I think it's not so easy, his question. He's arguing
No, I
about...
don't quite understand the question. Is this
So,
something else we can analyze the data with? Is that the question?
yes, almost. Ask again, Silvio. It's about triple negative, about in Brazilian environment. We still
Yeah.
have, if you think to improve your sample, to analyze the events more. É isso mesmo, Silvio?
Yes.
Yes.
I mean, the only thing we can do is wait for more follow-up, which we already have now 3 more years almost, to see if more events accumulate. But what I mentioned is that the patterns of failure for triple negative breast cancer show recurrence rates mostly by 3 to 4 years. Most of our patients have gone through that. So there's very few patients that actually with triple negative breast cancer in B51, they haven't been followed. As I mentioned, about 3/4 of the patient was already at 5-year follow-up. So those patients don't get many recurrences afterwards. So it's unlikely to have a lot of events that will come in triple negative breast cancer patients, but the pure math of the patterns of failure. I hope I make that point clear.
How do you explain your few events and the hazard ratio 2.4 for triple negative tumors?
Well, that's a good question. First of all, you have to say, is it a true finding or is it just a statistical aberration? And maybe, it's not a biologic phenomenon. A lot of people have speculated, maybe there's an immune-related effect when you radiate the lymph nodes that actually are part of the immune system in that area. But everything we can say is very speculative at this point. We have absolutely no idea why that is that. As I mentioned in my lecture, though, there is evidence from previous data that the triple negative patients may not respond very well to radiotherapy. And now we do have some studies that we're looking at the radiosensitivity index for patients. So maybe they would have either needed more higher dose if they have more resistance to radiotherapy, or they may not benefit at all. So we do have some data to support the B51 findings, but we've never sort of looked at that question before, right? So I think everything we can say at this point is more speculative. It could be an immune-related, effect of the lymph nodes, of the lymph node system. And of course, again, and I mentioned the point that every time we finish a trial, because the treatment has changed so much, it's very hard to apply the results to the standard of care now. For example, as I mentioned, pembrolizumab now is one of the standards for patients with high-risk triple-negative breast cancer, and this is an immune-related drug, which is a checkpoint inhibitor. So it's possible that patients that have pembrolizumab may not have had the same pattern of recurrence in B51. Maybe we will see this difference the other way around. But again, very speculative. I just don't have any data to support that. But I don't know. I mean, we cannot make any more data events. I mean, we have to wait to see how many events accumulate over the next couple of years. And I think we probably are already into every patient being followed for more than 5 years. So we'll present an update at some point. We're looking at the data now. Hopefully we'll present an 8-year update to make people more comfortable and see if anything is changing.
Dr. Mamonas, just one more question. About the localization of the positive node, lymph node, you always use the TED method in all your cases?
Yes. Yes, I have adopted the TAD method because when you look at the data critically, the false negative rate with the TAD method is significantly lower than with the simply doing sentinel lymph node biopsy for patients with clinical N+ disease at presentation. And of course, when we looked at all the data from the Z1071 trial, the Sentina, the Canadian trial, and the French trial, we see an average of about 12% false negative rate. And of course, then we said, but if you do dual mapping and you remove 3 or more lymph nodes and so on and so forth, you drop the false negative rate to the single digits. But even under that scenario, the false negative rate is in the high single digits, 8, 9%. But with TAD, we see consistently false negative rates in about 3 to 4%. So almost half of that. And again, there's no guarantee that when you go to do a sentinel lymph node biopsy after neoadjuvant chemotherapy for a clinical N+ patient, you will get 3 nodes out, right? Because it's possible that you don't find any lymph nodes, right? Because the identification rate is lower. And it's possible that you can find 1 or 2 lymph nodes. And we have data to support that not every patient, in fact, more than almost half the patients may not get to the 3 node mark. And that's what TAD comes into place, because even if you didn't identify any sentinel nodes, but just removing the clip node assures you that the lymph node that was positive was removed and now is negative. And even with TAD alone, with removing the clip node alone versus doing a TAD, the false negative rate incrementally goes up a little bit, like 5 to 6%. In other words, even if you just took the clip node out, you'll be better off than just doing the sentinel lymph node biopsy. So we apply TAD almost in every patient in our practice to avoid this situation where you find yourself in the axilla and you don't see any lymph node with activity, or you only find 1 or 2 lymph nodes.
Okay, Dr. Mamonas, thank you so much and for your brilliant presentation, and also to try to de-escalate the treatments and to try to de-escalate the morbidity to the patients. Have a nice weekend.
Thank you very much. Thanks for the invitation. It's a pleasure to participate.
Bom. A gente vai voltar às 14h10.